technical JCVI briefing from number 9 Downing Street. I'm Jonathan Van Tam, Deputy Chief Medical Officer for England. As is now custom and practice, I'm joined on my left by Dr June Raine, Chief Exec of the MHRA, and to my right, Professor Wei Shen Lim, who is the Chair of the COVID-19 Vaccine Subcommittee of the JCVI. Thanks all for joining. It remains nice to see people in person rather than down the camera. Today's briefing is about the UK booster programme. We won't be taking questions on other subjects. We'll be sticking to the technical detail of the booster briefing. I'll make a few opening remarks and then I shall pass to my colleagues. So I think I'd begin by reminding people that the UK has had one of the most successful COVID-19 vaccine programmes in the whole world. We've already seen the vaccines having a major impact on infections, but an even bigger impact on hospitalisations and deaths. And our latest estimates are that since we began deploying these vaccines, they've probably averted in the region of 24 million cases of COVID-19 in the UK and averted around 112,000 deaths. So incredibly successful to date and remains so. But we also know that this pandemic is still active. We are not past the pandemic. We're in an active phase still. We know that this winter could quite possibly be bumpy at times, and we know that other respiratory viruses such as flu and RSV are highly likely to make their returns. So with all of that in mind, the name of the game, the mantra if you like, is to stay on top of things. And that is why we asked JCVI to begin thinking and framing its thoughts around the booster programme back in the summer, and why the JCVI gave us some interim advice on the 30th of June. That set the direction of travel, but at the time it was too soon to boost people, and there were not enough data to understand how, when and with what that might need to occur. But it set the direction of travel, and most importantly, it framed the possibility of a booster programme for NHS England and for the Vaccine Task Force, who have been working really incredibly hard behind the scenes to prepare extensively for both the supply and the potential deployment of boosters if that moment came. So today is the time to clarify that announcement, to clarify the advice that I can confirm has now gone to ministers, and we await the response. The technical component of the briefing is divided into two parts. The first will be delivered by Dr Raine from the MHRA in relation to the licensure for COVID-19 booster vaccines, and then I will turn to Professor Lim for the detail of the recommendations themselves. Dr Raine.
Well, thank you and good morning. The Medicines and Healthcare Products Regulatory Agency is committed to getting safe and effective COVID-19 vaccines to the UK public, and this means ensuring that existing vaccines can continue to be used in the most effective way possible. Last week, as you know, we confirmed that the COVID-19 vaccines made by Pfizer and AstraZeneca can be used as safe and effective booster doses, as well as third doses in people who are immunocompromised. This is an important regulatory change. It gives further options for the vaccination programme, which has saved, as JVT has said, many tens of thousands of lives. The regulatory decision followed a careful review of all the available data on safety and effectiveness of booster or supplementary vaccine doses by the MHRA and by the Independent Commission on Human Medicines, which advises the government. The Commission took into account data regarding waning vaccine effectiveness after the second dose, which provided important insights into potentially waning immunity. We've also now looked at the Moderna vaccine to be used as a booster, and this has also been reviewed by CHM experts who concluded that the Moderna vaccine can also be used as a safe and effective booster dose, including in a half dose, which also gives an effective boost to antibodies. The data reviewed showed that giving the booster jabs with flu vaccines at the same time is safe and does not affect an individual's immune response to either vaccine. Therefore, COVID-19 booster doses may be given at the same time as flu vaccines. Finally, we have in place a comprehensive safety surveillance strategy for monitoring the safety of all COVID-19 vaccines, and this surveillance includes the booster jabs. As with first and second doses, if anyone has a suspected side effect, please report using yellow card. Thank you, JVT.
Thanks, June. I'm now passing over to Wei Shen Lim for the technical advisory detail from JCVI. Wei Shen.
Thanks very much. We will all remember that the COVID-19 vaccine program started about 10 months ago in December 2020. And the strategic aim of the vaccine program at that time was to prevent severe COVID-19 disease. That is to say, to prevent people from being hospitalized or, sadly, from dying from COVID-19. That primary aim has not changed. It's the same main strategic aim for the booster program as well. In the UK, we used for the primary vaccine schedule a 2-dose vaccine schedule with an extended dose interval between the first and the second dose for all the approved vaccines. That is to say that the first dose was followed by a second dose about 8 to 12 weeks later for the majority of people. That extended dose interval is relevant when we're considering the booster program. I could have just the first slide, please. When we're estimating the duration of protection provided by vaccination, the time period in question is from the start of the second dose and not the start of the first dose. That means that we can only really measure levels of protection out to about 5 or 6 months at this time point when we're in September 2021. Therefore, we have to project what the levels of protection might be 9 or 12 months after the second dose. That's moving forward into time, into December 2021, when we're in winter. The second thing to note about the extended dose interval for the second dose is that it gives a higher level of protection compared to a shorter dose interval for the first 2 doses. And that higher level of protection may also be relevant for duration of protection, because if we're starting from a higher level, then it may be that even with waning, there remains a high level of protection for a longer period of time. Can I have the next slide, please? The UK has one of the world's best vaccine surveillance systems, and the Public Health England, PHE, have been monitoring and analysing data related to vaccine effectiveness against hospitalisation. And this is an important point because we're interested particularly in hospitalisation and severe COVID-19. These data relate to vaccine effectiveness against hospitalization up to about 5 to 6 months. And because of the way the vaccine program was deployed, we have most data for people who are older. The data show that over time there is a small decrease in vaccine effectiveness from a little over 90% to a little under 90%. That still means that there's a very high level of protection, but we need to be aware that there's a suggestion here of some decrease in that protection as time goes by. When examined more closely, these data also show that the most marked decrease in protection occurs in the oldest people and in people who have underlying health conditions that put them at risk of COVID-19. JCVI has therefore taken into account these sorts of surveillance data, as well as data from recent trials that Dr. June Raine has mentioned, and operational considerations in coming to our advice. Could I have our next slide, please? Thank you. JCVI advises that adults who are more vulnerable to severe COVID-19 disease should be offered a booster vaccination in order to maintain a high level of protection through the next few months, so through this winter particularly. These people are identified as those who received their vaccinations during phase 1 of the vaccine program, and that includes the list of people that is on the slide. I'll just mention those: older adults living in residential care homes, all adults aged 50 years and over, frontline health and social care workers, those aged 16 to 49 who are in a clinical or otherwise risk group, and adult household contacts of immunosuppressed individuals. We also advise that the booster dose is given no earlier than 6 months after the second dose, and that the deployment follows the same order as in phase 1. We want to suggest a 6-month limit, as you will, as a lower limit, because we don't want people to feel they need to rush to have a booster dose. Getting a booster dose too early may mean getting a dose when they don't actually need to have vaccination because they still have a high level of protection. And as we've seen with the first and second dose, it may be that a longer interval to the third booster dose may actually be beneficial in the longer term. On the other hand, we don't want to wait too long before offering a booster dose. So trying to find a sweet spot between going too soon or going too late, we're suggesting that the booster dose is given no earlier than 6 months after the second dose. And as I said, it is deployed in the same order as it was deployed in phase 1. Hopefully, this will mean that the levels of protection that people have will be highest during the coldest months of the winter. In terms of which vaccine product to use, we are advising a preference for mRNA vaccines, that is either the Pfizer-BioNTech vaccine or the Moderna vaccine. This is based on a range of data from different clinical trials, including a very important trial called the Cough Boost trial, which was performed or conducted in the UK. And that trial showed that mRNA vaccines give very good immune boosting after 2 doses, after a first 2 doses of either the Pfizer vaccine or a first 2 doses of the AstraZeneca vaccine. In other words, it doesn't matter what people received with the first 2 doses, having an mRNA vaccine as their third booster dose gives a very good response. Therefore, the Pfizer-BioNTech vaccine is our preferred choice because of simplicity, it is well tolerated, and it has a good effect. And as an alternative, we're also suggesting the Moderna vaccine. I'd like to point out that the Moderna vaccine as a booster dose is advised as a half dose compared to the standard dose that was given during the primary vaccine course. And this is because the half dose works very well as well, has very good tolerability, and indeed is the dose that the manufacturers themselves are putting forward for booster vaccinations in their submissions to the EMA, the European Medicines Agency, and the US FDA. So the preference is a full dose of Pfizer or a half dose of Moderna as the third booster dose. There may be a few people who cannot have an mRNA vaccine for some other reason, perhaps there's a contraindication or an allergy, and in that instance, AstraZeneca vaccines should be considered for the third booster dose. Can we take the slide down, please? I just want to end by pointing out 3 important things that this advice today does not imply. The advice does not imply that there will be a recurrent program of booster doses every 6 months. The advice is only relevant for today and to protect us for the coming winter. whilst we're still in a very active phase of the pandemic. We will offer further advice regarding what to do when we come to perhaps a more steady state with regards to SARS-CoV-2 infections. The second thing that this advice does not imply is that it does not imply that everybody under the age of 50 who are otherwise healthy will necessarily need a booster dose of vaccine. We know from immunological principles that younger people tend to generate very good immune responses to primary course vaccination, more so than older people. So it may well be that younger, healthier people do not need an early booster dose. And the third thing to note is that the booster program does not imply that other vaccine programs are no longer important. And I'm particularly referring here to the annual seasonal flu vaccine program. Because we have more social mixing, we're returning back to normal levels, I hope, of contact, there will be more circulation of respiratory viruses, including flu. If somebody is eligible for the flu vaccine, I strongly urge that you also have the flu vaccine. We have heard from the MHRA and from clinical trial data that if it so happens that somebody is called up to have the COVID vaccine and the flu vaccine on the same day, then it is safe to have both vaccines co-administered, usually in different arms, but they can be co-administered on the same day. Thank you.
Thanks, Wei Shen. So I'm going to open for questions very shortly. So I hope that was a good and clear summary of the advice. It has been put to ministers. It is subject to ministerial decision. But if the ministerial decision is to go ahead, then it will be full speed ahead on this, but in a purposeful way rather than a rushed way. It is completely different to the situation when back in December and January at the beginning of the vaccine era, when we had very, very high levels of disease and a completely unprotected population. It's different this time, but it still needs to be purposeful, steady steps towards the goal. The final thing I want to say before I open is that the data considered and presented to you today and the findings are about boosters. They are not about primary courses, and all of the vaccines so far given in the UK for primary courses remain safe and effective and really important for people who have not yet come forwards for that primary course. That is really a very big goal indeed. I'm going to stop there. We've got some questions. The first is from Hugh Pym at the BBC. Hugh.
Thank you very much indeed. First of all, a question for Professor Lim. Can you give some hint of the possibility of future booster campaigns next year and whether AstraZeneca might have a role in that? And for Professor Van Tam, at what point will double jabs start, COVID in one arm and flu in the other?
Thanks very much. I don't think I can say very much about future booster programs because we just don't have the data. We don't know what might happen if you're projecting into December 2022. It's just too difficult to know for now. So I think we need to keep our options open. I wouldn't want to exclude any option at this point.
Thanks for the question. So double jabs can start now, subject to the availability of both products. We've heard from Dr Raine that the MHRA has looked at the data from the trials on giving flu in one arm and COVID in the other at the same time, and the antibody response to both of those vaccines is not impaired by doing so, and the tolerability of doing that at the same time is also fine. I would add that there is a practical reality to add on top, which is for the NHS to consider in more detail, and it may not always be the case that it is possible to co-administer all those two vaccines in every single patient. Sometimes it will be possible, and we should, gain efficiencies, and by doing that where we can. But remember that if you've ever been for your flu jab, it's quite a kind of rapid process to get down the line. There is a 15-minute waiting period with COVID-19 vaccines, an observation period, and meshing those two together in practical terms won't always be straightforwards. And so people need to understand that if they are offered the chance of two together, please do take it. I shall be doing that. But by the same token, they may not be through practical realities. And then, I'm not sure you were asking this particular question, but as a scientist, I will say it, that it's very much a matter for the future. But one day, I guess it's possible that the developers will come up with bivalent vaccines by organism. In other words, flu and COVID in the same jab. It's really not beyond the bounds of scientific possibility when you consider just how amazing a job it has been to get to where we've got to in such a short time. So that's always a possibility for the future. Thanks, Hugh. Emily Morgan.
From the data you just showed, it looks like the decrease in vaccine effectiveness over time is really small. So what is it that actually really persuaded you we need a booster jab if immunity remains really high?
Thanks very much. That's a very good question and very relevant. If we're running at a vaccine effectiveness of, let's say, 90%, and it drops to 80%, which is just a 10% drop, it may not seem like very much, but for a certain proportion of people who are being admitted to hospital when vaccine effectiveness is at 90%, then you double the drop. You might find that you're doubling the number of people who are admitted to hospital because of that small absolute drop in vaccine effectiveness. So it does have a big impact because we're talking about the entire population here, not just a single individual. And therefore, we're looking at this both from an individual perspective, but also this is a mass vaccination program, and we're looking at it from a population perspective. We will remember that last year in December, one of the urges was to save or protect the NHS, because by doing so we save lives. And that is entirely true for this winter as well. If we can protect the NHS, we will save lives in the broader sense as well.
I think the other thing I would add, Emily, is that the data that Wei Shen showed are, of course, data censored at the kind of September 2021 point. And the JCVI has had quite a difficult decision and quite a difficult judgment call to understand what that is going to look like by the time we get to December or January. And if you look at the trend and you follow the trend, and if you follow immunological principles, protection will have waned further by those points. And so that's an important consideration. It's an unknown, but it's a consideration that they have to kind of second guess where we might be if we don't act now in terms of the deep midwinter. And the brief from ministers has been very clearly to do the maximum we can to prevent morbidity and mortality from COVID until the spring. And so JCVI have rightly responded to that question set by ministers in the advice they've given. And I can see it, from a perfectly practical point of view. I don't know if many of you are used to kind of crawling into small tents on mountainsides. But if you do so, and there's a storm blowing, going to come up in the night, it's better to put some extra guy ropes on there and then than it is to wait until it's the middle of the night, it's howling with wind and rain, and you've then got to get out your tent and make your tent secure. And by the time you crawl back in, you're soaking wet. So it's better to be preemptive and to be prepared and plan for the worst possibilities. Ashish Joshi.
Two questions. Thank you. Good morning. Professor Lim, are you worried at all that the vaccine rollout programme for the booster might be perceived as a two-tier booster programme, because people don't really like alternatives? If they don't get the Pfizer and they're given what you called the alternative of a second choice half-dose Moderna, they might feel that their healthcare is being compromised a little bit, and that would impact on your rollout. And Professor Van Tam, what do you say to scientists, including our own like Andrew Pollard and the World Health Organization, that this booster campaign undermines global vaccine equity?
Thanks very much. I think the first thing to note is that we are advising a preference for mRNA vaccines overall. And so if somebody comes to a vaccination center or goes to a vaccination center and they're offered an mRNA vaccine, that is our preferred choice. The alternative between Pfizer and Moderna is more a question or more option for vaccination centers and deployment teams so that they can organize themselves rather than suggesting that an individual should be trying to find out where they can go to get a Pfizer vaccine compared to where they can go to get a Moderna vaccine. So I think the advice is given for different levels and for different audiences in order to enable that everybody gets the best choice possible.
Thanks. I'll just kind of nip in on Wei Shen's question, if that's all right, Ashish. I have seen, I sit in on all the JCVI meetings as an observer. I've seen the data they examine. I would be perfectly content as a 57-year-old and as a healthcare worker to be boosted with either a half dose Moderna or a full dose of Pfizer. I really wouldn't care which. That is just the truth. On the point about global vaccine equity and boosters, of course, as public health people, we take a very strong view that it is important that the whole world has access to vaccines, and that until everyone has access to them, none of us are safe, none of us are fully safe. We get that. By the same token, the job given to us is to define what is best for the UK, and that is what JCVI has done. I would finally add that based on the information my colleagues have given to me, 9 countries, and these data were roughly the end of August when they were censored, 9 countries have already announced that they are actively starting some form of booster campaign, and there is firm intelligence that 18 others are also considering it. So from that perspective, you know, the UK is not alone in thinking that it will need to do this to give maximum protection to its population this winter. Chris Smythe.
Thanks. Yes, firstly, can I just follow up on Emily's question? In terms of why you need to do this, is it just the data that you've seen here from this country on waning immunity, or are you looking at other countries' experience, such as Israel, to see where we might be heading? And then secondly, what evidence specifically have you seen that shows you that, what impact this will have and how effective this will be? And also for those who have had AstraZeneca last time, why you think that is not the right option this time? Because people might be thinking, you know, add to the general sense of concerns about that vaccine. And then just finally, if I can ask you all to give your expert opinion on what impact this campaign is going to have on the trajectory of the epidemic over the next 6 months or so.
Thanks very much. So we do look at information coming from other countries. The information from Israel is obviously very interesting and important. An important distinction, though, is that Israel used predominantly the Pfizer vaccine and used a 3 or 4 week dose interval schedule for the first and second doses. That means that they are, if you will, longer from their second dose to now. More time has passed, and also we know that there is likely a difference in the peak immune protection that you get if the second dose is timed at a different point. So whilst those data are important, they're not quite as relevant to the UK population as our own data. So we are looking towards the PHE data as our main source of data, because that is relevant to the UK population. In terms of the impact of the third booster dose, this is probably where we can look to Israel, where they have published data on how their third booster dose has helped them to reduce hospitalizations. There are various other reasons why that might be. It might not simply be because it's the booster dose. There might be questions around the variants and so on. But it does give some indication that a third booster dose can be helpful in the overall protection of a population. Certainly from the clinical trials, what we see is that the immune response, the measurable immune response, is very good after the booster dose. In many cases, it's higher than the measured immune response after the first and second doses. Therefore, if we get good protection against hospitalization from the first and second doses anyway, one would expect that with a third dose, where the measured immune response is even higher, you would also get a good or even better protection against hospitalization and mortality. So although the clinical trials on the third booster dose obviously haven't gone and measured effectiveness against hospitalization, we have every reason to expect that from what we can see, it will provide very good protection in that sense. And then you had a question about AZ.
Yeah, why are you not using AZ? And people who've had AZ might think, well, this adds to the sense that it's perhaps not quite as good as some of the other vaccines. So what would you say to them?
Yes. The AstraZeneca vaccine obviously is a very good vaccine for its primary cause. We've seen data that suggests that the mRNA vaccines, given whatever the primary cause vaccination is, gives a very good boost. And for a range of reasons, including simplicity in delivery of the program, we felt that overall there was a preference for mRNA vaccines for the third booster dose.
Yeah, so I think you had a kind of general question at the end there. So, June, would you want to say anything on that one?
Well, David, yeah, I'd just like to follow up on AZ and the regulatory position. Having looked at all the data, it is a safe and very effective vaccine. So no one needs to hesitate. And particularly, as Wei Shen says, if the decision is that you would have it for your booster, then no worry at all. Be reassured that it will be effective. So I hope that clears that up. In terms of longer-term impact, we, as JCVI, will be following Public Health England's really helpful and impressive and timely work to make judgments. Thank you.
Thanks. So I'll try and answer your question a little bit. I think if there's good uptake of the booster dose, and I've absolutely no reason to doubt that at all, you know, the uptake in this country, particularly in people over the age of 50, has been nothing short of astonishing. So if there's good uptake, I think the booster programme will make a very substantial impact on keeping the lid on things COVID-wise in terms of hospitalisations and deaths, and keeping pressure off the NHS this winter. We want to live our lives as normally as possible from now on, and we want a normal winter life too, and a high uptake of the booster programme is going to give us a much increased chance of doing that, in my view. Hugo Guy, iNews.
Thank you. Obviously, the delivery of this booster campaign will be done by the NHS, but Professor Van Tam, can you just say something about how soon you expect this to start, how long you expect the booster campaign to go on, and also, can you say anything at all about where these are going to be delivered? Is it going to be necessary to set up mass vaccination hubs, or can it be done within permanent infrastructure at a time when obviously the NHS is under quite a lot of pressure anyway?
Sure. I'm glad to answer that question. So my personal view is that this needs to start very quickly. The NHS has been planning for it for quite some time, months, and I would expect that they, subject to ministerial go-ahead, which at the moment I don't have, but subject to that, I would expect them to be able to start in a short number of days, not a short number of weeks. I would expect the model, and again, you really should ask the NHS for the proper details on this, but I fully expect the model to be a combination of mass vaccination centres and delivery through primary care. And of course, the all-important domiciliary outreach to patients that can't reach normal healthcare settings and need to be visited in their own homes. In terms of how quickly can this proceed, there is a very clear understanding that it needs to proceed with good pace. And of course, the advantage here is that this time patients only have to attend their vaccination location once rather than twice. So the simple maths says that it's quite obvious that it should be possible to go faster, in the sense that there are not second doses to factor in. But really you need a qualified opinion from the NHS England, who've really been all over this for months. So I encourage you to reach out to them and get some answers in detail from them. Thank you. Next question is Sam Blanchard from The Sun.
Thanks. The age cut-off seems like quite a fine line. Can you say what data you'll be looking at for younger adults and considering whether to roll out boosters for them, and whether they can be assured that 2 doses will be enough to see them through this winter? And also earlier in the year there was some talk about variant-specific vaccines. How confident are you that the current Pfizer jab is future-proof for the next 6 months?
Would you like to start on that, Wei Shen?
Okay, yeah, sure. Thank you. As you've probably worked out from the slide that was shown earlier, people who are 50 years and below without underlying health conditions would have been offered a vaccine, the primary course vaccine, much later. So they wouldn't have had their second dose until quite recently, really. And so even if they had immune responses that were similar to older adults, 6 months from their second dose would take them quite a long way into probably 2022, into next year. So we have time to try and understand more regarding how long their immune protection will last for. And when we have seen enough data, then we will be in a position to give further advice. What we don't want to do is for people to panic, if you will, and think that they need to have a booster dose straight away, because that may not be the case at all. Regarding variant vaccines, there are variant vaccines in development. The clinical trials that looked at the third booster dose also were tested to see if they neutralized variants of concern, and the immune responses actually looked very, very good against variants of concern. So at the moment, at least, giving the current generation of vaccines appears to still be very good against the known and major variants of concerns that we have now. Clearly, if there's a new variant that emerges, then we'll have to understand what happens then.
The next question is Hannah Giesler at The Express.
Hi, thank you. In the last couple of weeks, some GPs were affected by delays to deliveries of the flu vaccine. Are you confident that supply won't be a problem this winter for both flu and COVID? And secondly, recent ONS data suggests that around 4% of people might still be vaccine hesitant. We've obviously had really good uptake in the UK, but do you have any message for people who have still not had the first or second dose?
Okay, thank you, Hannah. So on the flu vaccine delays, that was from one manufacturer. My understanding is that that delay is very short, 1 to 2 weeks. I have absolutely nothing to tell you that gives me any concern about the supply of COVID-19 vaccines required for the booster programme. In fact, I believe it to be extremely healthy and absolutely no constraints on that. And I've forgotten the last bit of your question.
Are there any message for people who haven't had the first or second dose?
Yes. It remains the case that going from no protection at all against this virus to the protection given by those first 2 primary courses is always going to be more important in public health terms than boosting. It sounds crazy to say it at a briefing which is all about the booster programme, but it's actually true. And so from that perspective, the NHS has been very clear that the offer of vaccination is evergreen for people who haven't yet taken advantage of it, and they can come forwards, and it's still incredibly important.
Could I add to that? And thank you for raising that question. I'm a clinician, and I see patients in hospital, as do a lot of my clinical colleagues, who have unfortunately been hospitalized because of COVID-19. A lot of them currently are people who have not been vaccinated at all, whether with 1 or 2 doses. And some of them, unfortunately, are very, very ill. I've spoken to patients who have survived an intensive care admission because of COVID-19, and during recovery, we spent a long time chatting, and they asked me, when can I have my COVID vaccine now? And of course, we want to wait until they've recovered from their illness before we offer them a COVID vaccine. But the important thing is, if only they had asked that question before they became seriously ill and ended up on intensive care, because we want people to be as well protected as possible. And it's always heartbreaking when you see somebody who is admitted very, very unwell, and they didn't avail themselves of something that would have protected them from such a severe disease.
So I'm going to take one more question from the gentleman at the back. I don't know who you are, so could you introduce yourself to the panel, please?
Sure. Alistair Smout from Reuters News Agency. You've been very candid about the fact it's uncertain how long protection will last beyond 6 months, but said you want a precautionary approach, but said this doesn't mean that there's necessarily going to be boosters in the years going forward. I'm just wondering how we're going to break out of a cycle of constantly boosting if, let's say, this time next year, we're still taking a precautionary approach because we boosted everyone last year, we don't have enough data, and then more and more vaccine gets sucked into the developed world doing boosters and not to people who are unvaccinated. Thank you.
Would you like to go at that first? And
Yes, thank you. So that's a very, very important question, and one that we've been wrestling with for a long time and still are. We certainly don't want to be in a situation where we are taking a precautionary stance every 6 months and wondering if we ever can break out of a cycle. That would not be a good position to be in. We want to understand and learn just how long protection lasts for. There are major efforts being made to understand how the measured immune responses, so things we can measure from the blood and so on, correlate with protection against severe COVID-19. And if we have such correlates of protection, it becomes easier to measure immune responses in people and then have some sort of projection as to whether further boosters are going to be needed and how soon after. The other thing that is of interest is whether the third booster dose, by giving such high levels of measured immune responses, might actually last even longer than the second dose. And so whilst the second dose, we have started to see some hints of some loss, although not very much, it may be that with the third dose, that's pushed out even further to many, many more months. So that's certainly something to be encouraged about. And the last thing I would say is we don't really know how natural infection will help in giving us mini boosts on their own. You can imagine a situation where somebody has had natural infection first and then a vaccine. We find their measured immune response is very, very good. And the same may be true the other way around, i.e. somebody who's had a vaccine and then gets a mild infection afterwards. That mild infection may act like a mini boost to their immune response so that they continually have a high level of immunity that protects them against severe disease whilst they might get milder illnesses.
So that's a very, very comprehensive answer from Wei Shen, one which I agree with entirely. And, you know, the JCVI advice today is bespoke. It is for this winter only, and we will ask JCVI to keep on coming back to this question until the whole world, indeed, has settled into some kind of normality in terms of having to live with this virus. But now is not that time. The pandemic is still in its final, I hope final, active stage, and therefore we are under special measures, if you like, including asking JCVI to look at what we need to do this winter. But in time, I suspect it will settle down exactly as Wei Shen has said. I don't know if I'm allowed to keep on taking questions, but go on.
Thank you very much.
much. Lizzie Roberts from the Daily Telegraph. If someone in this group 1 to 9 chooses not to take up the booster, would you then consider that they are not fully vaccinated and therefore any COVID pass that they currently have would become invalid?
Thanks for the question. There is no current consideration of COVID certification in terms of the booster dose.
Would you consider that they wouldn't be fully vaccinated without the booster?
I would consider they don't have the optimal protection on board as a scientist. Whether there will be a ministerial decision about what constitutes COVID certification or not for boosters is something that ministers will need to decide on in the future. But that's a long way off, because you can't put in those kind of rules until everyone's had the opportunity to be brought forward and offered the vaccine in the first place. So, I'm pushing it into kicking the can down the road on that. I can be very clear that I would think that person was not optimally protected if the JCVI had advised that they should be. But in terms of what the government, what ministers decide on in terms of future COVID passports is not a matter we can really go into today. Final question.
Tom Harwood, GB News. I was just wondering, I've seen a lot of discussion about different vaccines having different longevity in terms of how protective they are, and some suggestions that the AstraZeneca vaccine might actually be lasting a little bit longer than mRNA vaccines. Was this something that has been considered at all in your deliberations?
I think that's actually quite difficult to answer. We don't really know how long the duration of protection is for most vaccines. You've seen some data that we've presented here. And I bring us back to the point that the primary aim of the COVID-19 vaccine program is to protect against severe disease. There are a lot of data regarding protection against symptomatic cases, but I don't think we can stop symptomatic cases completely, whereas we want a high level of protection against hospitalisation and people dying, and that's really where we want to focus on. So asking that question of different vaccines with regards to hospitalisation is much more difficult.
Okay, well, thank you, June. Thank you, Wei Shen. Thank you all for coming. Nice to see some of you. And this briefing is now closed.